Hi everybody, it's Dr. Linda of the Vascular Birthmarks Foundation here in Miami, just looking to see me on here. Wait a minute, where did we go? We gotta find our screen so we know where we are. Okay, where are we? I'm not seeing us. Oh, there we are. Okay, there we are. Perfect. Welcome to VBF Facebook live from Miami. I'm here today with Dr. Anna Duarte. It is not showing up on here yet, so let me just make sure I see us. There we are. We are here. We are live. Welcome
Thank
to
you.
the VBF February 2024 Facebook Live from Miami. I'm here with the Director of the Children's Skin Center, also the Director of Dermatology at Nicklaus Children's Hospital, Dr. Anna Duarte, and our longtime VBF expert. So thank you for hosting me and for our weekend of all things vascular birthmarks, right?
Absolutely, absolutely. It's great to be here again.
And we're going to be live for 1 hour answering your questions. And let me know, I can see that there are some of you on. I can see that you're joining us. So, anytime you have any questions, you can start because we're live and we shut down at 4:30. So you judge your time, and we will get to everyone. I have someone from my staff is on now. I believe Gina's on, and if you want to say hi, Gina, or something, so we know that, and put it in the comments, so I can see the comments section showing up. Let me just see. Okay. Yep, there's Gina. Hi, Gina. Hi, Liv. Liv McGregor is on, and Natalie Welch are on. Hi, ladies. Let us know where you're from. What countries, what city you're from, and like I said, Dr. Duarte's here. She's here to answer your questions concerning the diagnosis and treatment of infantile hemangiomas, port wine stains, and other various vascular birthmarks, CMTC, face syndrome, which you know a lot about. Hi everybody, I see that you're all on, and we can take your questions, but before any questions come in, you and I had an important discussion, and I really wanted to go on here so people can reference back about when people come to you and they bring their settings from other doctors for the laser, and you try to explain to them why that may not work. And so would you explain why you can't just go from one doctor to a different doctor and bring settings and think that setting's going to work?
Absolutely. So it's really important to look at the laser tissue interaction, and that's going to be dependent on the particular laser that you're using. Even day to day, that can change. So it's very important a laser surgeon knows that when they actually shoot that first pulse, they're going to look to see that laser tissue reaction is exactly what they want. And so sometimes someone will bring me parameters from another doctor, but their machine might be slightly calibrated differently. But even my own machine can change. Even if, for instance, if I got a brand new dye kit or it just got tuned up, I might have to tune it back a little bit. So really you can't go by a recipe. That's not the right approach. A lot of times it can work, but sometimes it doesn't. So every doctor should really analyze the patient's skin type. Sometimes a patient might get a tan and you have to adjust based on that. So you can't always just follow parameters from other doctors. That's possibly a setup for a little bit of a problem.
No, and exactly what you said, like people don't understand when a dye kit is changed, it burns very hot because it's freshly loaded with the dye. Just the same thing as when the dye kit's running low, you see yourself amping it up.
Exactly.
And you got to remember to dial it back when you replace the dye kit so you don't have any burns or whatever can happen.
And honestly, here in South Florida, we have to look at tanning.
Right.
Because tanning can really change the absorption of the laser. And so, if a person has a tan, it could interfere with the penetration of the laser, causing more of a blister. So even in that case, we might cancel a procedure, tune it down, less energy. So there's a lot of considerations.
Right, and I just think this is very important for parents to know, because they do think that they're going to be bringing these settings to doctor, and they always ask Dr. Geronimus, what is your setting? Dr. Garden, Dr. Coletti, Dr. Duarte.
And it's important to have a ballpark. I mean, the settings should all be within a ballpark, but they might not be specifically the same.
So, hello from Poland. We have some people on from Poland and from Florida. So as you all log in and ask your questions, let us know where you're from. We are ready to take your questions, and I hope you will go back and re-listen. As soon as this is over, you can watch it again and again and again on our website at birthmark.org. You can see the little YouTube icon at the top, and all of our lives are there from January 1st, 2017. We've had over 150,000 views,
Wow.
hour-long views of all of them since we started, and these are great for parents.
It's great information.
Yes.
Absolutely.
So hi Bernarda, and hi Dakas, and hi Despina, and Herman. We are ready, willing, and able to take your questions, so feel free. Hi Jennifer. I see a lot of you are on and listening. So we do have Free Laser Day coming up tomorrow.
Yes.
So we're very
excited.
excited. This is actually our first free laser clinic for our 30th year. So this is exciting.
Honored.
Yeah. And that's another thing. This is our 30th year, everybody. So we are heading into, hi Christian. A lot of people are on now. We are ready to take your questions. We are heading into our 30th year, so there's going to be a lot of activities with VBF throughout the year. So any questions regarding the diagnosis and treatment of an infantile hemangioma, port wine stain, face syndrome, cutis marmorata, even lymphatic venous and AVM. Oh, I see we have somebody on from New Zealand. Hello, Liv. She would like to hear your thoughts, Dr. Duarte, on treating with general anesthesia versus using numbing cream. Which do you recommend for a 1-year-old? I worry about the trauma of no GA, but also worry about the FDA warnings on the GA for under 3 years. Great question.
Yeah, so there's a lot of different things to consider when selecting the office setting versus the OR setting. The age of the baby is important. We tend to try to hold off going to the operating room. The child is 2 to 3 years of age unless there's an emergency, and try to get most of the treatments done in the office. Now, local anesthesia, topical anesthesia, also has its potential risks, so you have to look at the surface area to which it's applied. So if it's a small lesion, certainly a little topical anesthetic can be applied. However, looking at the surface area, larger lesions, you could end up with potential toxicity. So it's important to note as well that the laser shoots what's called it's called the DCD, dynamic cooling device, and this actually numbs the skin right before the laser fires. So it hurts a little bit, but it's not that it's going to hurt very much. And it's important to know that a lot of the crying that's going to be happening is because of the apprehension of the child. And so if you understand that in general these procedures are quick, and we can certainly console the child before and after the procedure right away, and they should be able to get it. This machine is really set up to be done in the office, and that's why there's the dynamic cooling. Now, very, very large surface areas, it can be a little uncomfortable, and there's some patients that are skittish and scared. Anxiety is normal for procedures, so we go to the procedure suite. So it's nice to have the option to do in office and within the OR, but there are a lot of considerations. I personally like to get as much done as I can in the office and then move to the OR setting if the child requires it after age 2 to 3 years.
And the other thing, I was talking to you about this the other day, is anxious parents can get a test spot done and see
Absolutely.
how the skin responds, and explain what a test spot is, because a lot of people ask me, what exactly is it? Is it 1 pulse, 2 pulses?
It varies. It varies. Sometimes on a parent, though, a test spot for the parent, and I often will fire the laser on the parent. It's usually just 1 pulse,
right?
So they can get a sense. This is really not that bad. It allays their concerns to a large extent to feel what their baby is going to be feeling. And then on the baby, I tend to not do test sites unless the skin is very dark. Sometimes I want to be sure we don't get a lot of blistering. What I tend to do is I start with a more conservative energy, do a full treatment, and then see how the skin responds, and then go ahead and crank up the energy, so to speak, each time, remembering that it's not just the energy that we're looking at, there's also the pulse duration that can be adjusted. A smaller pulse duration will cause more bruising, whereas a larger pulse duration, less bruising. Both treatments are effective. So some dermatologists or laser surgeons will want to treat with a lot of bruising. That's a shorter pulse duration. And then if you widen the pulse duration, you're still getting that same energy in, but you're getting it in over a longer period of time. And so there's less bruising. Still effective, because I get some parents coming and saying it's not bruising anymore. And that can happen too. The lesions can plateau, but you can adjust the pulse duration and get a bruise.
And also, I was excited to hear, I believe it's the Candela new laser that's going to be coming out is going to have that big size. And Dr. Geronimus always explains that, you know, even going from 8 millimeter size to a 10 to a 12,
yeah.
you cut down your pulses by 40-50%.
It goes a lot faster.
A lot quicker.
Definitely.
So that's my prayer, like bigger spot and less discomfort. So
absolutely.
Great. Hello, Esmeralda and Juliet, Mary Rose and Ava, Mary Frenette. Hello. Let us know where you're from. Ask us any questions. That was an excellent question. We get so much on the anesthesia versus not. And what I said yesterday to the residents was talk to the parents about different kids respond differently to pain.
Of course.
And I always give the lesson of me and my twin sister, where I have extremely high pain tolerance, and she just passes out at the slightest inkling of pain. She's just very fragile. So you know, each kid's different.
Absolutely.
I've seen kids jump off the table right after being lasered and say, "Let's go get ice cream."
Exactly.
Right? So hi Mary Rose, hi Ava Piles. It's always good to see you on, Ava. Ava is an adult that has face syndrome.
Okay.
And, well, obviously she had the infantile hemangioma. And I'm curious why she gets her lasers from Dr. Geronimus, and she has persistent staining where her hemangioma was over the eyebrow. And she has been getting a lot of laser. I don't know how many. She could maybe tell me how many she had. But maybe it's not. I'm wondering, why doesn't it respond? Why does that facey syndrome, infantile hemangioma tissue that's this old, why is it still vascular and not responding to the laser?
I would have to honestly see the patient and look exactly, because it should. Some blood vessels, the flow through them might be such that the laser just doesn't it can't reach it.
Yeah,
but I would have to see. But there are some recalcitrant lesions. I don't think it's all faces hemangiomas, though, because we have a lot that do respond very well.
I was just curious, like.
And it sounds like this one, most of it responded. There's like a recalcitrant area.
Yeah, she has an area that's just still very vascular, and it looks fairly like it's never been touched, but it has been.
Seems like maybe it's a flow issue, and
maybe
I know
we should.
Dr. Geronimus has every laser to address that.
I know. And I know Dr. Clutty's done ultrasound on her and basically said it's nothing, but I just was thinking about it myself the other day. Why are some of these so persistent?
Flow, the diameter of the vessels, and the depth. Yeah,
well, our factors. Johanna, hello Johanna, let us know where you're from. Natalie, again, I'm here with Dr. Anna Duarte. She's the Director of Dermatology at Nicklaus Children's Hospital, and also the Director of the Children's Skin Center, and a Vascular Birthmarks International expert. So any of your questions, we're here for you for this hour. Take advantage of having the expert here live. I see a lot of you are on, but you're not asking the questions, so you're just listening. That's why we just keep talking. But, you know, please ask your, hi Jane, we have another one on. I think we have a lot of people from the UK on. Another question, my daughter has had 10 treatments before she turned 1. Her birthmark is still responding. How many treatments is it likely she will need to get maximum clearance? It's a medium-sized port wine in the V3 region on her cheek and down her neck. I know every case is different, but hoping to get a ballpark.
It's really hard. I always tell my patients, that's the $1 million question. You really have to take it session by session and response by response. It's impossible to say. There's some patients that will need lifelong treatment. We just cannot, at this point, we're not stopping that malformation from reoccurring. we're destroying tissue and we're targeting tissue in a safe fashion. We're very fortunate to have these pulse laser systems, which we didn't have a couple decades ago. But we're just not there yet with the technology to be able to completely remove it. Even patients that we get 100% clearance, after 2 or 3 years, you might start to see the same footprint of the lesion coming back to some extent. So I guess my question back would be, in these 10 treatments, how much lightening has occurred? Is it improved
50%
80%,
or
80%?
80, yeah, and that kind of gives you, although isn't it true that usually that very first treatment can really be big impact?
Yes, but it sounds like they're doing everything right, because 10 treatments in the first year of life,
I know.
That's very good.
I was telling her, I had talked to this mom, I'm like, bravo for you, from being from New Zealand and getting somebody to treat this before age 1 10 times.
Absolutely.
VBF has a lot to do with that, where we did this Done by One campaign, trying to get doctors around the world to do it earlier. Lots of you on. Hi, Juliet, based in Australia. Thank you for always coming to our lives and asking questions. Now, Dana has a question. My 7-month-old son has KTS. Port wine is located also in the genital area. Is it possible to use a laser in that area?
Yes, of course. Even on the actual genitalia, if that's affected, it can be treated. You have to perhaps cut back on the energy. But yes, definitely the groin can be treated.
Would you put, would that be a child you may favor putting under some kind of anesthesia or not?
Possibly, yes.
Possibly.
I think that, when you're treating the groin just for impact purposes, it might be better for the child not to experience that awake. So I do patients that I'm doing biopsies or something for different conditions in the genital area. I tend to recommend that to the parents.
Yeah.
Just for the memories and things like that.
Yeah. I think that's better. A good idea. Yeah. So we have Nee on. Nee is from Ireland, and her daughter is 5, and she has a left side facial lymphatic malformation. Just here listening and learning. Well, of course, we know that sirolimus is being used. With caution, though, because there are, a lot of cases with the mouth sores. But alpelisib is really making its name in the market. And I believe it's Novartis, isn't it, from Novartis?
I think that's honestly one of the biggest, most exciting developments in the medical aspect since propranolol.
I agree. For managing.
Yeah.
So if you have the option, especially if your kids are on
and I want to clarify, the hemangioma is for infantile hemangiomas, but I'm just saying within vascular birthmarks, this to me is a huge development. The alpelisib, the V-joist is huge for the overgrowth component.
Yeah, I agree. Lots of people on. Let us know where you're from. What is your maintenance treatment framework for a V2 facial port wine after the 2nd year of life? For reference, we had 18 treatments beginning at 2 weeks old.
I think that you have to talk with your laser surgeon and come to a maintenance plan. It's going to depend on the child, how much the child is experiencing in terms of anxiety for the procedures, whether you want to continue to treat. It depends on what kind of purpura you're getting, what kind of response you're getting after the treatment. Some of these lesions do plateau, and you actually get some benefit from giving it a break and coming back and getting a better laser tissue reaction.
It grips it when it's
let it recover a little bit, and then you get more. So there's no one answer. It's something that you need to talk with your doctor about and come to a treatment plan, maintenance treatment plan.
And I tell everybody, you'll know when you're in maintenance when the last 2 to 3 subsequent treatments yield no further improvement.
Perhaps.
Then it's reached what it can reach at that time if you haven't change settings or whatever, because there's a lot of little things you can do.
Absolutely.
So that was great. Oh, this makes my heart so happy because Liv, the one from New Zealand, said, it's all thanks to VBF that my daughter had her 10 treatments before age 1. So they bring in this stuff in our videos and our booklets which say to start treating. So hallelujah, New Zealand. I'm so excited. Hi, Stephen. Hi, Shaza. She is also from the UK. She's been taking her 2-year-old son to Dr. Coletti, yay, for laser, and he's had 3. The last time I noticed not all the port wine was treated. Could there be a reason for this? It healed so much faster this time as well.
So a lot of patients come in with that same concern, and certainly the initial treatments are going to yield more purpura, and as you improve, there's less of a reaction. As to why he might have left some areas untreated, you definitely want to let it heal completely. So if I have some patients, for instance, with hyperpigmentation, in the healing process, I'm not going to treat those areas. But that would be a question for Dr. Coletti specifically as to why some areas weren't treated.
And you know what? I tell every mom, outline the area that
Yes.
you expect to be treated with a white eyeliner or something, but just make sure it doesn't have formaldehyde in it or anything that's flammable, because that happened once with a patient used
goodness.
eyeliner, but I don't know where she got it, but it did have something, and Dr. Geronimus was lasering and it started flaring.
Oh my gosh.
So he's like, you better make sure you tell everybody not to have formaldehyde,
Goodness.
which is used in a lot of
Yeah,
cosmetics.
absolutely.
But this is, Liz also brought something up that I want you to address, because it happens with so many babies that get treated for their port wine, this eczema phenomenon
Yes.
on the stain.
Yes.
So how do you take care of that? And do you retreat that area the next time, or how do you manage
So
this?
if the patient comes in with a lot of eczema over the port wine stain, I usually reschedule, because you want to get that under control, because it's going to impede the laser penetration. There's inflammation there, so it's not ideal. And then if the patient has eczema coming in, I have them treat in advance. I want that eczema under the best possible control for the laser treatment.
So what do you recommend?
On the face, hydrocortisone a couple times a day should definitely get it under control right before treatment.
And that's okay for a baby?
Yeah, absolutely.
Now, some of the patients say there was no eczema there, but after the laser, it developed a type of eczema, and I've seen that.
Yeah, so it's not the laser at all. These lesions tend. It's a well-known described
Phenomenon. That it's just random occurrence that they're both happening.
It actually has a name and everything.
Oh.
We'll look it up afterwards.
Yeah. Okay.
So it's not unexpected to have eczema within a port wine stain, but definitely want to have that cleared up, tidied up right before laser treatment for sure. Plus, it's uncomfortable. Eczema tends to be itchy, and you don't want a child scratching after a
Right.
port wine treatment
That's
and
true.
possibly injuring the skin. So it's important to control that.
That's true. Hi, Nee. So Evie was on sirolimus. That was the one with the lymphatic malformation. She's now on Alpelisib.
Perfect.
Hey, we got this down. We got this down. She was the first in Ireland who started at Bravo.
Wow.
Nee, I'm so proud
That's
of you. She had 5 KTP laser on her epiglottis, and the results of the Alpelisib on her tongue allowed us to remove her trach. Wonderful. I need you to email me at vbfpresident@gmail.com. I'd like to talk to you more about this, because I really want to get this message out to other parents with
This is
these kids with
fantastic.
lymphatic malformation. So Nee, please, Gina, my Director of Marketing and Communication, she'll put in here my email, which is vbfpresident@gmail.com. So just scroll down through and you'll see it, so you can reach out to me. I'd like to see some photos of your daughter, and I'd like you to write something up about being on the sirolimus, what the experience was like, and then having the laser, the KTP, which I'm really happy to hear, especially that she's had the trach removed.
That's
I mean,
amazing.
it's just
Fabulous.
great job, Mom. Okay, Andrea, she is from Chicago. My grandson has a facial port wine and has had 3 treatments and has responded wonderfully. I can't tell you how helpful you all have been in these past 15 months. Your passion and info is incredible. Thank you.
Thank you.
Thank you. Yes, I'm probably going to Dr. Garden. Dr. Jerome Garden. He's one of our experts. Great. Oh, okay, it's Katie. It shows up as Nee, N-I for her name. She's the one who has the daughter with the lymphatic. Okay, Katie, thank you. Write to me, though, and I'll see, somebody should, yeah, there it is. I think, Gina will post my email. So Tuesday Morning Star says, hi from the UK. My 10-month-old has what his dermatologist refers to as an extensive cavernous hemangioma covering the back of his right hand, half of his fingers, and a thumb and part of the palm. Currently treating with oral propranolol. Here to learn everything I can. Thank you for the opportunity. You know, they call those glove hemangiomas
Interesting, yeah.
because they look like the kid is wearing a little red glove.
And how is it doing?
Yeah.
Are we allowed to ask questions
Yeah,
back?
yeah, she can text us back. So,
Yeah.
how is it responding? Is it lighter? Because it can get to a point too where they can introduce some laser.
Absolutely.
Right? Like when it's like the propranolol does not, which people think, it doesn't always make the red part go away. Usually makes the bulk shrink.
Right.
Right. So sometimes you need to go back in and clean these up with a laser. Wouldn't you agree? Okay, Natalie's next. What would I be looking for in terms of purpura changes to know we have plateaued? Would I be looking to see less bruising?
Yes, less bruising. But you have to make sure they've tried different parameters that are safe before saying, okay, well, it's plateaued. So like I had mentioned, if the longer pulse durations will have less bruising. So when that happens, if they shorten the pulse duration, you can try that to see if you get more of a bruise. Because what happens is the energy penetration is different. So with the shorter pulse duration, the energy penetration is more superficial. And so that's why sometimes you want to vary the pulse duration between 0.45, 1.5. I mean, there's longer pulse durations, but mostly with port wine stains, we stay with the 0.45 and 1.5 milliseconds if you're dealing with a Candela Prima device in particular.
I just learned something new. So if you're using a shorter wavelength, it's more superficial.
It's a little bit more superficial, so the longer pulse durations,
the deeper.
yeah, the same energy will go a little bit deeper, yeah.
Very
And there's
important
also,
information.
And there's also the blast effect, right? So you're delivering
right,
that energy shorter.
The scatter blast, or
Well, with the shorter pulse duration,
right.
the same amount of energy is going to be delivered faster, so it's
right,
more,
because it's more concentrated.
yeah, correct.
Hello, Bernarda from Croatia, Zagreb, Croatia. Her daughter has Facey syndrome. The hemangioma was around the eye. It was treated with propranolol. She's now 8 and has had two or maybe something laser treatments. She must have been 2 or 3 laser treatments. She still has some remaining red surface.
Okay.
Is laser still a good option at this age? What dynamic of laser treatment would you recommend? Thank you. Hope to meet you in June in Milan. I hope to see you. I'll be there.
I won't be there,
But I will be.
yeah.
So,
yes, as long as you're getting some purpuric response, the laser is still being effective. I would treat as long as you're getting a response. In terms of parameters, I think is what she's asking with the dynamic. What dynamic? Maybe parameters. It really does depend on the machine. On each
right.
laser is slightly different. There's different manufacturers. I personally have a Candela, but for instance, Cynosure makes a pulse dye laser as well. So this is something that you need to discuss with the doctor to see the parameters. And for my V-beam Perfecta, I usually range in my energies anywhere from 6 to 8. My pulse duration between 0.45 and 1.5, and my spot size, I usually stay between the 10 millimeter and the 12 millimeter. But that's my laser, and that will vary depending on if it just got serviced, and it will depend on the patient's skin type and whether they went out in the sun and got tan. Everything has to be considered.
and that's a very important thing. And by the way, we're catching up. There's a lot of people on. We're catching up with questions, so you can submit your questions, and we will get to them. I mean, I can't explain this enough to the parents, especially if their children are in the process of getting treatment, about the sun.
Sunscreen is
Not
key.
just sunscreen, but the hat, the sunscreen.
Yes,
and
absolutely.
especially like, do you tell your parents, like, if you've lasered today, like you'll laser tomorrow, and they say we want to go in the pool tomorrow, do you tell them that wait a few days, or do you just say use sunscreen?
So definitely the next day to go in the pool, I say avoid the peak sun hours 100%.
Okay.
So maybe, after 4 o'clock or early morning.
Okay, that's important to know.
Sunscreen only works so far, right?
Right.
They definitely need to wear a cap. It depends what part of the body. So yeah, definitely, because what ends up happening is you'll end up with post-inflammatory hyperpigmentation that can last quite a while. and that actually interferes with the penetration of the laser. So you're setting yourself back a little bit.
Hello, Ahmed and Yusuf and KS and Natalie and Joe. We're happy to, if you have any questions relating to the treatment of any vascular birthmark, we're here to answer those questions. That's why we're here. That's why we go live once a month, is to enable you to be able to ask the doctors directly. Hello, Wayeed Khan. Thank you for joining us. And again, I'm telling everybody, if you have a question, this is the time to ask Dr. Duarte. Hello, Anwar. This is the time to ask Dr. Duarte your questions regarding treatment, whether it's a port wine or a hemangioma or venous or lymphatic or arteriovenous or Facey syndrome or Sturge-Weber syndrome, Klippel-Trenaunay syndrome, and CMT syndrome. Those are the 9. Those are the 9 we represent. So, and we're having a great discussion. We are halfway through. It's 4 o'clock. So we do have 30 minutes left, but that's going to go by really quick. So make sure you get your questions in for us. I learned something new, especially about the wavelength. When you shorten it, it's more superficial. So I'm going to be thinking about that a lot, because especially the ND-YAG goes very deep, so that's why it's a long pulse, right? Because it's a long pulse.
It's not exactly the wavelength, because in the pulse dye laser you don't vary the actual wavelength.
Right.
The pulse duration
The
and
pulse
the
duration.
energy.
And
Yeah.
so the pulse duration, you can adjust that. That's
Yes.
That's
Yes.
what it is. Okay.
But in some lasers you can actually change the wavelength. There's some lasers that give you those opportunities. Like I have one laser that has a 755 and a 1064.
Right, that's the Prima though. That's what it had,
Well,
right?
the Prima has that too.
Right,
Yes,
the 2. And
exactly.
I think that,
But no, the Prima is a 595, I believe, and 1064.
right, because
And
it has the
but the
YAG.
Gentle Max, which is the Candela one, has the 755, which is the Alexandrite, and the 1064, which is the
it is,
YAG.
okay, because I know the Derma V, I think, has the YAG with the pulse dye, or maybe not.
I'm not
Or I thought
100%.
he said he could switch it back and forth. But anyways, it's
Yeah.
important stuff.
Yeah.
Important stuff. Hi, Jackie. Jackie's on. Jackie Lally. Nice to see you, Jackie. So she said, my daughter's eczema on her birthmark has been flaring for 5 months and only clears up short term with a very strong steroid cream. We have had to pause treatment due to this. Do you think a food allergy may be driving this?
So in general, eczema is not related to food allergies. Food allergies are more related to urticaria, or commonly known as hives. I have parents ask this question quite a bit. There are rare situations where a food will be a trigger for eczema, but it's not most common. So they need to just look. Eczema can be controlled. We have great creams for eczema. Depending on where on the body, we have topical steroids, we have non-steroidals. So I'm not really quite clear on why this eczema hasn't been able to be controlled, because we have really good tools to control eczema. We do it every day in the office very successfully.
She's in New Zealand. I'm not sure, like, if they should.
Yes, these are commonly available medications.
She's already got her on a strong steroid cream.
Yeah, and that sometimes causes a rebound. That could be part of the problem. So
maybe back off from the steroid cream.
So the way I talk to my patients and try to counsel them is I start with mid-potency steroids. So in pediatrics, I rarely go to a high-potency steroid. So a mid-potency steroid is something like a triamcinolone or a fluticasone or a mometasone. These are mid-potencies in the cream form. And then that and lower. And these are safe to use on the body. I use hydrocortisone 1% on the face. But what I really try to impress on my families is that it's important not to abruptly stop the steroid. So you go twice a day to once a day to every other day. A slow taper is really important. Moisturizing is key, and there's 3 main components to eczema on the skin. There's an inflammatory cascade that's revved up, so that's what the steroid is going to calm down, and the non-steroids. All these topical anti-inflammatories creams are meant to kind of slow that down, control it. But the skin barrier is also missing some oils called ceramides, and so you want to hydrate the skin with the good moisturizer that contains ceramides. So usually it'll be a cream or an ointment. And sometimes you have what's called a dysbiosis. You have too much bacteria. There's an imbalance of the bacteria on the skin. the microbiome, which is, you know, a hot topic now on the skin. And so sometimes we'll have to look at adding a little topical antibiotic. So these are all reasons that maybe it's not getting better. Maybe the course is too short. The steroid is you know, abruptly stopped, and the steroid is too strong, and you're getting a rebound. Maybe there's a little bacterial infection there that could be addressed. Maybe it needs to be moisturized in between. So I don't know the specifics, but these are the things that we keep in mind with eczema.
I guess I was thinking like the mom, and I was thinking in my mind, would I try like a children's Claritin, you know, which is an antihistamine.
So eczema, believe it or not, has a small component where an antihistamine can help, but it's not as IgE driven, let's say, as urticaria.
I know, because you already answered that it's not like an allergic reaction.
I mean, it's a sensitivity, a hypersensitivity. Yeah.
Okay, we have a Hi Tuesday. That's her name, Tuesday Morning Star. I like that. She started treatment at 4 months. Actual age adjusted would have been 8 weeks. Wow. So 2 months early.
Okay.
Due to him being preterm and low birth weight with borderline low blood sugars between feeds, at that point his hand absolutely did look like he had a little puffy red glove on it. It was so puffy I had to floss between the folds of the fingers with a wet wipe, and I think nothing else would fit. People don't even understand what the moms and dads go through. He's been on propranolol since the end of August of last year, and it is a lot less red and significantly less puffy. He can use his hand like normal now, thank God.
Yes.
And I can clean between his fingers with a wipe over my finger as a comparison to having to floss it before. Thank you for the info that lasers could be an option for when the propranolol has run its course. Although the red has reduced, there is still significant color to the area. Our review with the derm is in May, so I will discuss this with her. Beautiful.
And later on, depending on how that skin remodels, remember over the next 9 years, it's going to remodel quite a bit because there's going to be possibly some fibrofatty residual tissue. And now, you know, we're using radiofrequency microneedling to address that in older children because it's quite painful, but in older children. So there's a lot to be done if there's any residual fibrofatty change.
Yeah, there's options to smooth it out.
Exactly.
And the sooner the better. I mean, you just don't want to have the kid getting picked on or, you know, some people saying stuff. I don't know. To me, it would, I don't know, would you wait?
It depends. It depends on the situation. We would have to take it on a case by case because it is painful. It would not be that particular technology would not be tolerated in the office in a child.
Yeah.
And the anesthesia is kind of heavy. It could be a little bit dangerous, risky for absorption in a child in the office because of the surface area.
Of course.
So it would require OR treatment. So it depends. But there's treatment available, which is the message I'm trying to
that there
convey.
Are options.
Yes.
Options.
Absolutely.
So Dana has a question. She said, Dr. Linda mentioned lymphatic malformation. Remember that one that switched? Yep. Is the laser treatment applicable for lymphangioma? My son with KTS has lymphedema, microcyst on his leg and buttock. We are currently using sirolimus, which helps a lot.
I would definitely consider alpelisib. But yes, you can do some laser to help the superficial aspect, which is called, in the old days, we called it lymphangioma circumscriptum. Now we call it just a superficial component of the lymphatic malformation. I've used pulse dye laser as well as electrocautery. Sometimes, and you can talk to your doctor about this, the sirolimus solution, and there's actually now a branded topical sirolimus, which is called Hifter, that can be used for that component. But the sirolimus, it's very expensive, hard to get. But our own oncologist here said, it's kind of like a little hack, that you can use the oral solution topically, but talk it over with your doctor for that superficial component.
That's very interesting.
Yeah.
Somebody had something that I saw. I was going to ask you, if there is cutaneous stain, and we think it's, well, sometimes we call it lymphangioma circumscriptum with a lymphatic component, right?
Mm-hmm.
Can the laser potentially make that worse?
Potentially it can, so I only treat these if the patient's having a problem. Because these have deep roots, so to speak,
Right.
and the laser's only going to address a superficial aspect, it could trigger seeping for a long time of lymphatic fluid. It could open the door for infections, which we don't want. So I'm very cautious. That's why I'm thinking the topical Hifter, the topical the oral sirolimus used topically would be a better approach. Only laser if you're already running into problems. I actually like electrocautery because you're going to get some cauterization, so some sealing of the vessels.
Yeah, I'd like to find out about that. Is it Hifter? How do you
Hifter, Hytor, Hyftor, Hifter.
I haven't heard about that, but I do want to know about it. This is one of the reasons I like going to the ISFA meetings, is because when I go, I always find out what new drugs or anything they're even
It was only
discussing.
recently. It was only recently approved and
Yeah,
it's
but I
commercially available. It's just very difficult to get.
Yeah, but in our group, the discussion groups with the lymphatic malformation moms, they should know about that.
Yeah, absolutely.
So, okay, so we are caught up and we have 20 minutes left, 19 minutes left. So we can take more questions from you. These are great questions, by the way, and you actually are helping each other. Most of you are moms, some dads here, and adults with birthmarks, but when you describe what you're going through with your child, and then we provide our feedback, you're helping the other moms that are on as well, and the other dads. So Rizwan just joined us. Hi, Rizwan. If you have any questions, any of you, regarding a vascular birthmark diagnosis or treatment, please ask Dr. Duarte and myself now. We are here for 18 more minutes. And there's a lot of good information on here if you're just joining us. She answered a lot of really good questions on lasers, when you're in maintenance, the eczema that sometimes happens, so you can go back and re-listen to these.
And general anesthesia
And the general
versus in-office procedures.
And another thing I wanted to ask before we get to our next question is, do you recommend a certain type of sunscreen and a level of SPF?
Yes, so I think that when you're undergoing laser treatment, you should use the most SPF possible. And the studies have shown that it does make a difference in terms of its effectiveness. So there is an SPF of 100.
Eucerin, Neutrogena.
Neutrogena and La Roche-Posay have 100. I would recommend that because it's going to be well worth it if it doesn't, to keep it from interfering, the sun exposure, keeping it from interfering with laser treatment. So an SPF of 100. But officially, the Academy of Dermatology recommends an SPF of 30 and above. Key for sunscreen, you need to get it applied at least 30 minutes before heading outside and reapply every 2 hours.
Wow.
Otherwise, you're not going to get the appropriate effect. That's why sun protective clothing and hats and sunglasses, umbrellas, avoiding peak sun hours, the rash guards that the kids wear to cover up as much as possible, and just need to rely on the chemical sunscreen for smaller surface areas.
Great. This is Parto and I have been talking. Parto June is on now. Her son has the V3 port wine, but very pronounced lip hypertrophy.
We just talked about this.
Yeah, and her and I have been going back and forth because I've been dealing with another mom whose son has had 3 debulkings. He's 16 and he's had 3, and they've paid cash for each one of these, and they've come back within 18 months.
See, I think that we talked about it when we saw this patient here in our clinic, right?
Right.
That maybe there's something different that we haven't discovered exactly yet, right? That
Right.
These there may be a role for V-joists in these, and there's some literature available already for the PIK3CA inhibitors on these that tend to overgrow like this.
Yeah, she asked trametinib and sirolimus together. Do you think that would work too?
No, I'm not familiar. I think that's a MEK inhibitor, right? I think that Dr. Khatib says yes.
I'm not sure.
But I
either.
can't answer that exactly. It's, you know, I don't use those medications specifically, so I'm not 100%. That would be a question for Dr.
Yeah.
Khatib. We can get back to you on that, though.
Yeah, I mean, I've been texting her this morning, you know, because I'm trying to, I know that Dr. Coletti is experimenting with, will his new electrical sclerotherapy approach
Yeah.
prevent the recurrence? You know, is there something that he can do so that those vessels can't recanalize?
Exactly.
We're hearing from this group that I've been meeting with. I've had a couple of Zoom sessions out of China. They have a new, I'll call it a technology because it's not a laser, but they're claiming no recurrence after 4 treatments with this new type of photodynamic type of therapy.
Yes.
So the concept that I'm thinking of, though, is if we can get that for the bulkier lesions, like, you know.
That I was actually asked to participate as a study site on one of those studies. It's just quite complex. I don't feel like that we're there yet. I know that in China they were doing some work with this, and it's an IV infusion.
Yes.
And then the exposure.
Yeah, and you got to cover your whole body.
There's a lot of risk in terms of sun exposure after that, because really what that treatment is doing is creating it creates a temporary porphyria in you.
So you have to really stay inside.
You have to protect.
Oh gosh. I mean,
we have to.
As scientists, we have to look at this and understand it. But that's why I want to go, because they want me to go to Shanghai to observe in their largest treatment center. I want to talk to the families. I want to find out what the experience has been like for them and the recovery and the healing. But so anyways, I've been talking to her about Dr. Coletti's new technique, and I'm not sure if it would work with that much of a lip. Can he do some debulking and then try the electrical sclerotherapy to keep it from coming back? But
and maybe in combination with alpelisib.
Could be. I mean, she's anxious to have something done before he starts college. But again, you can get it debulked. Like, I could send him to some surgeons on the West Coast, but I don't want it coming back 8 months later.
Yeah.
You know, and then why did this come back? This was Liv's question again on the numbing cream. Other than the numbing cream, are there any other options for pain relief for a 1-year-old or something to relax the child?
So it depends on how extensive this lesion is. These procedures are fast, so maybe a little bit of infant Tylenol, that would be the most I would do.
What about the Sweetums? Have you tried those, the little sugar things you pop in their mouth? Because I called St. Jude's Hospital to see what they use for all of their injections, and they said they use Sweetums, that they're little capsules, and it gives them about, they said, like 5 to 30 seconds of a little loopiness.
Yeah.
So we have Leslie Graff, our child life specialist, said that there are a lot of surgery centers that use those to kind of chill the kid.
I think that you have to have a certain credentialing.
Yeah, I think you need to have an anesthesiologist.
Yeah,
maybe.
and so in general, in doctors' offices, I like to stay safe. If the child gets a little bit upset, I know the child is safe. When you start to do these things, you could get into complications.
Right.
It's just not worth it. The procedures are so quick.
I know, and it's 50-50. So either the laser, parents think may be traumatic, or going under general anesthesia is traumatic. We already know that going under GA.
I've been doing this for almost 29 years, and I haven't had any parents come back to me with any kind of complaints or concerns. Right. I'm sure it's the same for other doctors that have been practicing even longer, that the children, do well. I haven't had that.
Juliet has a question. She reoccurring eczema on a previously resected AVM port wine stain. So I don't know if it's a CM-AVM. Been using clobetasol, 0.2%, sitting borderline to deep muscle and skin graft. located on buttock, recurrence for 2 years now, reoccurring for 2 years. Any suggestions?
So clobetasol is the strongest possible steroid that there is, so it can thin the skin. So it should not be used long term. There are non-steroidal creams such as tacrolimus, pimecrolimus, which can be used more long term. In addition, there's Eucrisa, which is crisaborole, which is also a non-steroidal used for eczema. I don't know how severe the eczema is, but clobetasol used for many, many years can really thin the skin. You can get stria, atrophy, telangiectasias from the steroid itself, or try using a weaker steroid, as I had mentioned, the fluticasone, triamcinolone, mometasone. I think that would maybe be a better approach.
Yeah, I guess, I don't know, maybe Juliet, you can see my email in there, vbfpresident@gmail. I'd like to talk to you a little bit more about this because you said the AVM was resected, and it's in the buttock area, so I don't know if he's having any recurrence or what was done, because we have an AVM study going on. That's why I'm saying this to you with Dr. Coletti's new technique, and we're seeing some great results. Jackie has a question. Her 10-month-old daughter has a port wine on her left cheek, near her eye, scalp, and neck. She has had 22 treatments so far. I'm considering taking a break between treatments. She has had great clearance, and I'm nervous taking a break will affect this.
No, don't be nervous. It'll be fine. We talked about this a little bit earlier. Sometimes taking a break, when you come back to it, it actually will have an even better response. So, and you may have a sustained clearance for quite a while, maybe forever. I mean, it's possible. But there are also cases where 100% clearance, and you'll start to see it come back a few years later. So if you're not getting a lot of response, I think it's time to take a break. It depends on how much bruising you're getting at this point.
Victoria has a question. Her 2-year-old daughter has a port wine on her face and has had 18. Oh, we took a break. We took a break, but she has eczema on her face now that we keep battling. We will get it cleared up with the dryness, but it still is bright red where the eczema was. Will that eventually fade with time, or could the eczema have left a permanent mark?
Yeah, eczema doesn't tend to leave a permanent mark. So I would have to see it. Certainly, you can email me pictures through VBF or directly at pddermdoc@aol.com. I would have to see it, but eczema doesn't generally leave any sequela whatsoever. It can temporarily look pink. I tell families it goes from red to pink, sometimes even to white or whitish, and then come back to normal skin tone. So you may be still in the healing process of the eczema. But yeah, that'll go away.
Yeah, I would say
if it's eczema, it'll go away.
She should just take a break and let it clear up.
Yeah.
Right? Just let it clear up. I mean, you've had 18 treatments and she's 2. I often wonder too, is there a point where it becomes hyperplastic? If she's had 18 treatments before age 2. She doesn't say what level of clearance she got, so I don't know if it's 80 or 90. But then she said the dryness and the bright red, and I'm not sure if she's the mom that wrote to me, but there was a mom who, it actually looks darker after laser.
I thought I understood the question wrong. I said that the treatments had done great, but then now she's
got eczema. We took a break, and has an eczema that we keep battling. Mm-hmm. We will get it cleared up with the dryness, but it is bright red. Yeah. And I've been having these kind of questions from moms that say it's darker than before they even started laser, but it's got a crust on it, like this eczema over where the port wine was, and 2 of the doctors in our network will laser through that. Others like to wait for that to clear up.
I like to wait for that to clear up. But it seemed to me that now she's mostly battling the eczema. So, again, I'm happy to look at a picture and try to counsel you on that.
Yeah,
but eczema doesn't tend to leave permanent marks.
Yeah, and Gina can post, there you go, thank you, Gina, she just posted Dr. Duarte's email.
Thank you.
So it's right there, thank you very much.
And one way to kind of tell also is to put pressure on the skin and see if it blanches.
Oh, that's a good idea.
Okay, because if it blanches, you can see that's more vascular.
Yeah, that's more the port wine.
Yeah.
But if it doesn't, because we say that too with the hemangiomas, when at birth or within that first week, you're like, is it going to be a face syndrome hemangioma, or is it a port wine? So we tell them to blanch, because the eczema is not going to blanch.
No.
But the port wine will. So if that super red lesion, she's saying, you put your finger on it like this and press it. If you see white, that's the port wine. So that's not, it's
Excellent.
weighing in towards the port wine.
Yeah.
So we have 5 minutes left.
Wow,
See,
time
I said
flies.
it went by because people started putting their questions in. We've had a lot of great questions. And again, go back, re-listen. You'll say, what did she say? And go back. And that's what's the beauty of having these Facebook Lives on our website and our YouTube channel, is you can go back anytime you want. You can share the links with new moms who have a baby with a port wine and say, hey, go look at these videos. You can download our booklet, the hemangioma one. You were one of the authors of that one. We have the port wine booklet. So, you know, go there, look at the resources that we have. And we can take another question because we have 4 minutes. So let's get your questions in. Thank you, Gina. Yes, it's been a great session. Gina said so. Gina has lymphangioma circumscriptum, and she thought it was a port wine. So she's really likes that. She's a part of our whole story.
Absolutely.
And I like that too, because every time I see her, I'm like, no laser. But some people do, but I don't think you're supposed to when it's a flat, like a lymphangioma circumscriptum. Have you ever tried lasering them?
The lymphangioma circumscriptum?
When they have that stainy look.
If it has a big vascular component, I think it would respond okay, but like I said, we have to weigh the risk-benefit of maybe triggering some, lymphatic seepage for a while, or risk of infection. Hifter, the new drug that I'm going to research. So again, we have 3 minutes. 3 minutes left, everybody. Get your question in. Thank you, Gina, for, she's had electrocautery for the blebs. Yes.
That's all that she's had.
Yeah, the electrocautery is what I tend to do more, because it will give you some cautery and hemostasis. There used to be the nice advantage about Hifter is it's not commercially available. Before, they were compounding it, the topical rapamycin. You could get it from a specialty pharmacy, but now you can get it if your insurance will cover it.
Are you thinking about that, like using that with laser treatment with port wines, or no? Like how they...
No, this is for lymphatic malformations.
Oh, I know, but I'm saying they used Rapamune in the past.
I tried that. I didn't get it.
And that's what Dr. Geronimus said, and Dr. Nelson said they thought it was meh, not. But a lot of parents still do write to me and say, hey, this doctor's using topical sirolimus while lasering.
Yeah.
And they're thinking it's getting more clearance, but there's no sufficient research where you treat one area with it and one area without.
I did try for a while, and it really didn't pan out for my patients either.
Okay, so now we have the answer to that. Well, it's been a great session. We're down to 2 minutes, and I don't want to leave anybody's question unanswered, so if you post it here, Gina will get it to me, and we'll get you back your answer, but we have another minute, so if anybody has a final question, a final thought, again, you can go back and watch these. Tomorrow is our laser day here.
Yes,
so
exciting.
If you're in Miami, I'm here.
Come to Nicklaus
Children's and ask for Dr. Duarte and Dr. Linda. And we have I think we have like 15 patients coming tomorrow, so this is all part of what VBF does. And I tell people all the time, I think we're the only charity in the world that does free laser, free ultrasound, free dental, free psychotherapy, free consultations. And bravo to us for being 30 years doing this. Oh, we do. We have a question. So, we had that one already. Okay. Thank you very much for sharing your knowledge. It's very much appreciated. That's for you from
You're
Jane.
so welcome. It's my pleasure.
And Katie, I'll talk to you so you can write to me. All right, everybody, so we are logging off, and I'd like to thank you for today's session.
Thank you for the opportunity, Dr. Linda.
Yep, and you can go back and rewatch this, rewind it, rewatch it, go back and look at the other ones, and we always get new information like the new drugs that she's talked about today, which I'm going to do my research on. So thank you for letting me know about that.
Of course.
So be safe, everybody, and enjoy. Let's see what's coming up next. St. Patrick's Day. We'll see you next month. I believe I'll be with Dr. Gregory Levitin. Next month will be all things surgery. So join us next month with Dr. Levitin. So thank you all. God bless, and we'll see you next month.
Bye-bye. All right.